Great. So today is the culmination of a 3-year project funded by the ERC that had collaborators all across Europe, more than 30 collaborators. And so today is a kind of, we always meant to be a sort of summation of that research that was going to be held at LSE. And so I'm really glad to see a lot of our partners here today, and they'll be speaking through their panels as well. I also want to thank the Firoz Lalji Institute and Tim Kimalan, who's centrally involved in this project now. He leads one of the work packages from LSE. And thank you so much for hosting us as well. And if you want to send any Twitter comments out, please go to hashtag LSE COVID Commission. So I'm going to begin the day by talking about some of the findings and recommendations of the LSE Commission for Pandemic Governance and Inequalities. This has been a 9-month project that we really a sort of multidisciplinary experiment in investigating the relationships, the policy relationships that emerged through COVID-19 and what to do about these policy relationships in the future. And we've had 5 important partners in this work, this very multidisciplinary work. They are CEPS, the Centre for European Policy Studies, which is a policy think tank based in Belgium. The Karolinska Institute, which is a medical sciences university, LSE obviously anthropologists, behavioral scientists, many constituent groups within LSE. And FLIA, which is a professional organisation of medics, European Academies of Medicine. But the most important partner of all, I think, is Leaders Unlocked, which is a social enterprise that brings young people, young adults in particular, to comment on policy making. And you'll be hearing from them later on today as well. And of course, they're the most important participants because they will be the people who are taking the world and the policy within it in a new direction, and will probably be the people who suffered most from the pandemic with their education restricted, and also will be making policy for pandemics in the future as well. So what was the approach that we took to pandemic governance and inequalities in our commission? Well, over 9 months, we took a retrospective and prospective analysis of UK and EU governance. So we looked at the past and what we could learn from that, and what we could learn from particular policy relationships about what to do in the future and what to do now as well. We were particularly interested in multi-level governance, or in other words, the dynamic interactions between macro levels of governance, meso and micro levels of governance. And this is quite unusual. Usually commissions of inquiry or big events like pandemics look at events and how events unfurl. But we were really interested in these dynamic interactions across all levels of governance and their impacts. And at the core of our arguments was the idea that inequalities are reproduced by government policies, knowledge practices, and longer-term structural inequalities. So we were putting both the question of inequalities in society and how those were regenerated by policies, by the government, putting them within the same frame of analysis. And we worked with the principle that health outcomes in various social groups was a form of embodied inequality. So health outcomes from COVID-19, for example, were a result of long-term structural inequalities, policy during the pandemic, and policy during the pandemic. And we were interested in this core question, answering this core question, which is which forms of pandemic governance intensify inequalities and which reduce them. And in other words, we were using slightly clunky term, but it's the only way of expressing it, a biopsychosocial calculus to measure the value of policy. In the past, I've taken a social calculus to look at policy, which was thinking of policy to what extent it exacerbated or increase inequalities in society and information society. But here, we're also thinking about the biopsychosocial biopsychological. So just to give you a stronger sense of what this inequalities approach is, I wanted to give you a clear example of the ways in which inequalities are generated from multiple intersecting forces. And this example comes from some work that I did while I was on stage about the high levels of mortality in the second wave of the pandemic, of particularly Bangladeshi and Pakistani groups. So the rate of death was high for all ethnic groups in the second wave in the UK from October 2020 to January 2021, but it was highest for Bangladeshi and Pakistani groups. The question that we need to ask is why was that so? Well, when we looked at that in a multidisciplinary team, We saw that it was in part due to long-term health inequities, for example, the emergence of diabetes over the life course due to environmental and work factors. It was also due to the disadvantage of not being able to work from home. Most people in these communities had family businesses, they had to keep them running. They also might have been working in transport as taxi drivers, and therefore they had to keep working. And in combination, that meant that people were bringing back the virus to crowded multi-generational households. So it's the sort of home and work situation that intersect. There was also the problem of stigma, the sense that these groups had that they were stigmatized by greater society and which reduced their health-seeking behavior. This especially came after the cancellation of Eid by the government, suddenly by Matt Hancock in May 2020, which produced a great outpouring of concern. And it was unclear why that celebration of all was cancelled when a month later or so, we had Rishi Sunak's Help Out to Eat Out scheme. There was also the influence of national policy. There were no national interventions from October, November 2020, as SAGE had advised, and furlough schemes didn't support family businesses or people that were in small enterprises. And there was also the government at the national level refusal of the idea that there was any structural inequality by policy advisors in particular, special advisors in particular. And also another key problem here was that there was only retrospective population level knowledge. That was the only thing that the government would use to track the outcomes of the pandemic. And of course, if you're using retrospective evidence, you can't do anything about what's already happened. And they were using that rather than taking seriously live qualitative evidence that could see the impacts on different populations in real time. So we can see that this inequalities that were generated for these groups, which produced very large amounts of deaths among them, sort of tragic consequences, shows you how important integrated work is, that this is explained by a biopsychosocial perspective. And I just want to point this out because I'm still very shocked by this, because the government didn't really take up any of the recommendations of this SAGE paper. We can see that the rate of death amongst particularly Bangladeshi groups was still the highest amongst groups in the UK post-vaccination in the third wave. So what was our methodology when we brought together this multidisciplinary team? Well, what we wanted to do was we didn't want to look at how events unfolded. We weren't using kind of judicial model here. We wanted to go to local experts who had knowledge of key policy related things. So local experts could have been in the cabinet office, that was their locality, or they could have been in neighbourhoods, in Ealing, for example, on the places where we worked. But we wanted to really find these people who were experts on a range of policy relationships, multiple relationships. These were also people who were noble people that could look across a wide range of networks, not just policy networks, but also social networks within society. And these were also people who were mediators, who turned policy into social action itself. So they had to deal with the frictions and difficulties of translating policy into real action on the ground. And what we did was we then calibrated the responses of these people with a particular social field, with a particular social institutional structure of power. And we actually gave the greatest weight in our evidence assessment to people at lower levels of governance and or in close relations with disadvantaged groups, again, because they saw the strains and tensions of actually what happened when policy intersected with society, or when people tried to create new policy upwards from society. So we talked to people in international organizations, in the EU, in regional authorities, medical professionals, civil servants, citizens, voluntary sector organizations, and community activists. And so our method was really to look at public health governance as relationships and relational work. Now, in our methodology, we also focused on several core intersecting themes. And these themes were ones that had emerged through the whole course of the 3-year Charismatic project, and were also themes that we've seen as important in our first bit of scoping research as a group, which you can see a link on the slide for a link to that report. So these 5 intersecting themes was the issue of how public health governance had worked at macro, meso, and micro levels through the pandemic across Europe and the UK, and what the intersections, the sort of intersections between these levels have generated in combination. We're also interested in the question of public authority, how was legitimacy and trust created and broken during the pandemic. We're interested in what evidence and data was used to make decisions during the pandemic as well, and what hierarchies of knowledge that involved, and which forms of evidence and data were lacking, and which might be helpful in the future. We're also interested in social infrastructures or the networks of formal and informal care that stretch between state and society, that is so essential to getting by and support during pandemics and outside the pandemic. We're interested in what has happened to those during pandemics, especially in the times of national lockdowns when these social infrastructures have been broken. How did people survive? What sorts of provisioning had worked, both in the voluntary sector and in society? We're also interested in what health frameworks different institutions were using. And one of the ones that we were interested in exploring was particularly the perspective of One Health, that looks at health both as an environmental, as a biological, and as a human and a non-human relationship. So these were our core intersecting themes. And as you'll notice, these are also the themes for the event today. So what we're doing is we're continuing these themes in the conversations. If you look down the list, you can see that this dynamic growth of our research, I think, is going to happen more today as well. And we'll include what's spoken about today in our final commission report as well. So what were the recommendations that we had from looking at public health governance at these different levels and their intersections? Well, what we found is that we needed to, for the next pandemic, to prepare for it, we needed to find a balance between centralization and decentralization of health measures. Obviously, more decentralized forms will better match the socioeconomic situation. So it was when local authority, public health officers, for example, were given more authority within the UK pandemic, that the information that became better at the top levels of the UK government, and it meant that measures could then be designed also to fit better at local situations. But importantly, this decentralization should not be an excuse for governments not to fund properly the provision of healthcare during pandemics or in between them. These forms of decentralized structures need to be centrally resourced and monitored, but using context-specific measures. But there's a problem if you use particular audit measures from central governments to look at the effectiveness of policy, because those may not at all match the activities, the really valuable activities that are going on the ground in local situations. Instead, you need to negotiate for each context what the impact measures will be, and to do that in a co-produced way with voluntary sector organisations. We saw very clearly that in the pandemic, the role of voluntary sector organisations and local public health and care services was absolutely crucial. When there was a strong infrastructure, social infrastructure of CSEs and local public health care and services already before the pandemic, health outcomes and policy outcomes were much better. And our recommendation would be that we need to build these centralized and decentralized structures now to provide better health outcomes in the present and to create better pandemic preparedness. This is a core theme in our report, actually, that the measures that we want to take for the next pandemic are not just to deal with the next pandemic situation, they're also to level up, sorry to use that word, but also to create a better health situation overall in the present. There should also be a reduction of the centralization of power. This is another key finding for us. Scientific expertise should be entirely independent of government and appointed through a transparent process. It's not really clear how different experts became experts on scientific advisory committees. And what we suggest is that there's a whole process of selection and creation of scientific expertise in the present that is transparent and involves, a discussion of how connected these scientific experts are with different government departments already. The evidence basis for decisions should be made public. We saw in the UK that when SAGE's advice and recommendations were made public due to public outcry from June 2020, it created a much wider debate in society about what should be done and what could be done. And we think that should be the model for other countries as well. We also need to tackle this really huge question, and here we need the help of many kinds of academic work and non-academic work, people working in the voluntary sector, for example. We need to think about the legal and ethical responsibilities for pandemic governance. These need to be formulated and made explicit, and there needs to be a democratic discussion of these. This is really necessary, because what we had in the pandemic situation in places like the UK was basically a few cabinet ministers making all the policy decisions. That is not democracy. So we need to talk now about what are the legal responsibilities of governments during times of pandemic. And I think this is a very special situation where all normal forms of democracy and rule of law are sort of suspended. So we need to create special responsibilities for that time. And we also think that macro level organizations need to be strong voices against inequalities. For example, around issues of vaccine solidarity. This is a huge issue. And there needs to be a pre-planned procurement supply chain, and this could be a role for FLIA to get into the EU situation. So we'll be hearing more about that in one of the panels later today. So what were our recommendations about evidence and data? What seemed to work really well during the pandemic were cross-ministerial committees that collated data and evidence to solve a particular problem and build policy. And they also started to explore the possibilities of data integration across sectors. So, for example, in the UK, the initiatives to house rough sleepers were implemented by a cross-ministerial committee, and they created new forms of data in order to create very successful policy for housing the homeless during the pandemic. Now, in some countries like Finland and the UK, there seems to be an emerging potential for this kind of cross-ministerial work. Within the UK, we've got a new health structure. We've got the Department of Health and Social Care, and underneath that sits the NHS, the UK HSA, which is the health securities body, and the Office for Disparities. And within the NHS, we've now got a plan for integrated care teams, which look at social care alongside healthcare, all the way up the system and all the way down the system. So we need this kind of cross-ministerial work, and that built into the structures of governance. We also think that scientific advisors should be fully multidisciplinary, and all disciplines should be represented as central advisory committees. In many contexts, under the subcommittees, there was a very multidisciplinary format, but then when you got to the central advisory committees, it was mainly formed of public health experts, epidemiological experts, and modelists. And we need to really think hard about that, whether that was the right combination at the decision-making structure. We also need to improve the understanding among decision makers of the value of qualitative social sciences. Now, our argument for that is based on the fact that actually ministers, policy advisors found qualitative evidence, found qualitative evidence to be some of the most useful evidence during the pandemic, in particular because you could use it to map inequalities in real time. And so we need to have a really full-on campaign to make this qualitative and social sciences more accepted inside government. Now, something that fell out of conversations quite early on in the pandemic was the idea of smart NPIs. I don't know if anybody's actually heard of this term. So around sort of May 2020, in a few settings across Europe, an argument began to arise that we didn't need to have total lockdowns or total national local restrictions, but you could actually build what we call smart NPIs that actually close down particular work sectors if they were particularly risky for the transmission of COVID, or you close down, it's mainly around work, actually, work context. And that actually never got anywhere, just because there wasn't enough data to say, for example, what were the most risky work environments. So what we need to do now is we need to really build multidisciplinary teams that analyze the epidemiological evidence from the last pandemic, and then start to think about what smart NPIs could be so that we don't have to go into those mass lockdowns again, the next pandemic. We also need to build the capacity for social listening and co-productive policy. We found out that where that was practiced, for example, in the community champion schemes, that it built much better policy and much greater acceptance for policy at the local level. Now, it's really important that this social listening and co-production isn't just the representation of groups on committees, and actually that's the direction that's been taken in the reform of the UK NHS at the moment. BCSE organisations are being represented on committees across areas. You actually need to do that hard work of engagement with social listening around particular policy measures and structures at the local level. There's also a question of evidence for whom. Who should the government and local authorities be generating evidence for? Obviously, most of the time they're generating evidence for themselves, but there was a real call to make more data open access so that more organizations could be involved in an informed way at the local level about how to act better during a pandemic. So for BCSE organizations or local communities to act with knowledge, there would need to be more open access to data at the local level. And there also needs to be, this is something that we'll be talking about in the data panel later on, there needs to be an exploration of the legal measures and relationships that could create a link between private and public data. Public data with mobile phone companies was extremely helpful in some contexts in the pandemic, but there were limits to how much access that the governments could get to that private data. Public authority, there are so many things that I could say about this, and we're going to have a whole trust lab in a moment. But just a couple of recommendations that I want to pull out here. Public authority is the creation of legitimacy and trust. But what we discovered is that pandemic strategies that call on a we, on a whole total social group, and their mutuality, and the focus is on care for the advantage will be the most legitimate way to go with pandemic policies. We didn't see that in the UK, for example, where there was a very punitive kind of sort of pacing for pandemic strategies. We need to ensure protection is given to those unable to follow recommendations, and that economic and social support is given to the vulnerable. And local authority teams started to give economic and social support to disadvantaged groups that then caused a much better following of pandemic regulation, for example. So there needs to be a call on mutuality and the support of the most disadvantaged in society. And what we learned actually also from both experts and people in BCSEs and from citizens is that legitimacy will come from a reform of the care and public health systems, because we live in what I would call a post-COVID world. Even though there's been a normalization of the pandemic, actually people have been dramatically affected by their experiences of COVID and really imagine the world differently if we live in this post-COVID world. And this means that we all have a deeper understanding of the gender burdens of care, the unequal effects of COVID-19 on disabled, elderly, young, and minoritized groups. We saw this across all levels of government and amongst public. So we actually have a broad we in this post-COVID moment. And so we need to use this, we need to really activate this to demand the reform of care and public health systems. And legitimacy and trust, we also found out, is likely to increase if governments resource voluntary sector organizations. So what we'd argue is that this will generate the best form of pandemic preparedness and will reduce biopsychosocial inequalities in the present. Social infrastructures, as you already would have guessed, we think that BCSEs are essential in many aspects of pandemic preparedness, but also for the general health of the population. We think that they should be included in all levels of pandemic preparedness and response. In the UK, they were not part of the RED committees, which were convened by the Army to govern what should be done during COVID here, but they need to be included in this. They also need adequate sustained flows of central government funding, as they had under New Labour. But perhaps we need to create new structures for this, which are a bit separate from government, because government's priorities change and we don't want to make BCSEs too dependent on these political variabilities. So maybe we should think about a national infrastructure plan, as was mooted in the last election by the Labour Party, that included social infrastructure. There should be equitable and inclusive funding and commissioning at the local authority level, which means that micro-organisations are really skilled up and are enabled to gain funding. There needs to be a service integration of health and social services, I've already mentioned, at the local and national level. We should consider a Ministry of Care, as has been explored, but not taken up in the Scottish Government in recent months. And in terms of health frameworks, the big message that we have seen was that the experts and members of the public consulted now understand health in the round as linked to multiple social and biological factors. Post-COVID, we have a common understanding of health that's holistic and recognizes the significance of the environment, its nature. This is what we found. So our recommendation is that this is not only a great time to demand more of our governments in terms of healthcare and social care, but it is also a time where we can create more awareness of the nexus between humans, animals, and the environment, and how the spread of zoonotic diseases happens in the interactions between these. And one way towards this is to make One Health more accessible and easier to implement in various sectors and levels of governance. There's a clear message that people understand that they wouldn't use this term, but that the biopsychosocial includes the human and the non-human. So I'm going to have a provocative conclusion, which is that our key finding, perhaps, and our recommendation is that we should start thinking about calling for an international declaration of pandemic rights. There's an unacknowledged social suffering from the COVID-19 pandemic, which still continues, which has been normalized, and we push back against that if we're going to get reform and change. The pandemic centralized power, and we need to ask whether we want that power centralized within the hands of a couple of ministers. What actually should democracy be in a pandemic, and how is it best assured? There should be a big push in this Declaration of Pandemic Rights for vaccine solidarity and rights to vaccine. And this, I think, could lead to a broader discussion of what health and security are and could be, including One Health concepts. It would help us to argue, to make an argument to build rights to the vital social infrastructure that we have during and outside of health crises. And I think it could tackle these biopsychosocial embodied forms of inequality. We've experienced a huge event that has not been normalized. I think that this call for an international declaration of pandemic rights find a wide support both in the UK and around the world. So I hope So thank you very much. That's really a kickoff for a day of exciting conversations which cut one of these threads. So now we've got two panels running simultaneously, one of which is in this room, and the other one is in EAR 102. So if you get lost, since Liz and
Follow me.
Yes, follow me, Peter. That's for the panel.